isn't it? Says your life.
Hey GP learners, hopefully you can see us okay. This is working. We're trying a slightly different way of showing you our digital primary care update, in which me and Andy are doing it through Zoom. And the reason we're doing this is trying to improve the bit rate and that kind of stuff, but hopefully you guys can see us okay. How are we doing today, Andy?
Yeah, not too bad. Been a busy week. First week in the COVID hub at Riverside Bulwell. So that's been very interesting, but otherwise okay. Still cough and fever free. How about yourself?
Yeah, doing okay. So I was self-isolating the other week and things because I had a fever episode. Apparently tested negative. Not quite sure what that means. I was fairly convinced that I probably had contact, because I don't get fevers normally. But yeah, the test says I'm negative. Whether that 70% sensitivity, specificity element of things is playing a part, we'll see. But I guess we're here talking with our EGP learners about what's going on in the COVID world and our digital primary care update. And I guess one of the things we wanted to cover in this episode, we've got a bit of a focus on COVID hubs, because both myself and Andy have been quite involved in setting up our local ones. In addition, we've got quite a few resources for you coming towards the end in terms of stuff that you can use to try and help you manage coronavirus and the other kind of things for your patients and with your staff. And we've also got one interesting article we wanted to cover that has come up previously in our other episodes and stuff, and we just thought it'd be worth mentioning and spending a little bit of time because we thought it was an interesting thing to discuss. But we're starting off with the hubs, aren't we, Andy?
Yeah, so I suppose first of all, it's just worthwhile acknowledging that things seem to be getting more serious with COVID-19, and obviously there's been some obviously multiple deaths of NHS staff. So I feel it's just important that we just acknowledge that, really, and that people are out there trying really, really hard to deal with and cope with COVID-19. Also very nice, people were clapping on my street on Thursday night, so it's really heartwarming to see the support of the general population of the NHS and what they're doing at the moment to help with COVID-19. So that was really good. I just wanted to say that, really. Things seem to be getting busier a little bit. I think for the last few weeks it's felt a little bit fairly quiet in primary care. A lot of the routine work that we've been doing has been paused while we've switched successfully, I think, to a telephone first service. And as we've been setting up the hubs, it just feels that things are beginning to get a bit busier to me with regards to COVID. So well, how have things felt for you at work the last few weeks, Gandhi?
Yeah, I mean, fairly similar. I mean, like I said, I've been self-isolating for the past week, and I've been itching to try and help out and do stuff. One of the interesting things we've had locally is that they've started giving us access through remote desktop functions, which has been quite groundbreaking, in particular in Nottingham area. So you don't actually need a IT certified laptop and stuff in order to do so. You can just access it with any kind of laptop through a secure portal. Bizarrely and annoyingly, I got access to that the day I went back to work, so it was slightly frustrating in that respect. But yeah, it works really well, actually. So I've been able to do a few things, and actually some of our EGP learners would have seen my intro to System 1 user guide that I actually filmed using that system, because I was able to do it from home. But apart from that, work is, it's starting to get a bit more challenging. The hubs are seeing a bit more footfall. And I think people are seeing more cases coming through, and particularly the triage and that kind of stuff. So keen that we can understand how hubs work and what they do and all that kind of thing. Yeah, go for Andy.
No, I was just going to say, I'm hoping that if we do have some people watching at home, and if they're involved in their local hubs, that they'll be able to comment in the comments section and give us a little bit of feedback about what's happening in other areas of the country. We're all watching our WhatsApp and seeing lots of news about how things are working in other areas of the country. But it'd be great to have some of those comments live, I think.
Definitely. So, I mean, how was the setup from your point of view in terms of the hubs and stuff?
Yeah, so it's been really, really interesting, because we've been asked to do something really quite complicated in a really short space of time. So it's been really fascinating just to see how we've done that and to see what we've done. And I think we've actually done fairly well, but it's felt a little bit of a stretch at times. I suppose talking about it from the technology point of view, obviously before the hubs exist, you've got to organize them and form your team and so forth. And I think technology was really helpful in our PCN, and well, across Nottingham. We work quite closely with all 8 PCNs in Nottingham. We've been having daily Zoom meeting with all of the PCN leads from all of the 8 PCNs across Nottingham, which I think has been really helpful, talking about how we've been going about setting up our hubs, sharing information about our protocols and procedures, the problems that we're encountering, the solutions that we've developed, and then now just how we're running on a day-to-day basis and learning from what's happening at the other sites. That's been facilitated mainly by Zoom, which we've talked a lot about here, and there's lots of resources on EGP Learning for how to use Zoom in all sorts of different scenarios.
Yeah,
that's been really helpful. WhatsApp, Microsoft Teams been really obviously helpful as well for sharing those documents and communicating away from the video meetings. So that's been really, really helpful. So shall I talk you through the setup that we've arrived at?
Yeah, go for it.
We are just.
But important to recognise both me and Andy work at different hubs, and our hubs are completely different in the setup as well, because we're catering for different geography, catering for different population sizes, and obviously structure of the buildings themselves. But yeah, talk us through your version.
Yeah, so I think you're right. I think that actually the physical geography of the building and the car park plays a really big role in what a hub ends up looking like in my experience. So we are working together with another primary care network. So in Nottingham, we've kind of paired off. So we've had two primary care networks working together to create a hub. And that's partly because of the buildings available in Nottingham and where they are. And it's partly because we acknowledged it's a big job for one primary care network, fledgling organisation, to develop a hub themselves. So we've paired up. So we're in populations of roughly sort of 80 to 100,000 patients. We've got 16 practices across the two primary care networks, and so that's what we're working with to create the hub. We are located in a lift building, so we're quite fortunate to have a building that has a sports hall with showering facilities. Adjacent to that, there is some purpose-built clinical rooms, about 20 of them actually, that are normally used by community services who aren't doing as much of their routine work at the moment, so they've been able to decamp to other clinical areas sort of upstairs to where the practices are. So the building is shared by 2 of our primary care network GP practices, including my practice, but it's a big building. There are 3 entrances, so it's quite easy to partition the building out so that we've been able to continue cold work at the normal GP practices and have the hot suspected COVID work going on in the clinical management centre, which is what we're calling these hubs in Nottingham. So just talking through, really, I'll take a patient journey through the hub just so that people can understand what happens. So people are arriving sometimes on foot, but more often by car or by taxi. We've set up a bespoke taxi service in Nottingham City, which I think is a great achievement, using the Hackney cabs. So those are the traditional sort of black cab style taxis where the back is designed to be wipeable. Obviously, people sometimes, if they go out, they've had too much to drink, or there's some sort of other accident in the back, they're designed to be cleanable. So and the driver is screened off, so that's ideal. So we've got an arrangement with one of the taxi companies to enable patients to come in a taxi if they don't have their own transport. So they arrive. On arrival, the patients will alight their vehicle and come to the building, and just out the door, we were going to do it outside actually in a marquee, but it was windy on the first few days that we did it, so we moved just inside the door. We have what we're calling the arrival assessment point, and we've got a senior clinician there supported by 1 or 2 sort of other healthcare trained workers, so nurse or healthcare assistant. And as soon as they arrive, we check their details, bring up their information on the computer, actually often before they've arrived, because we know that they're coming. Check the history, check the triage information, and then we do a SATS and respiratory rate assessment at that point, and clarify some elements of the history if we need to. And actually, at that point, we make a decision based on the algorithms that we've got and the clinical judgment of the senior clinician there as to whether they're green, their oxygen saturations and OBS are within acceptable limits. And we think it's a classic COVID presentation, and they're able to actually leave the site with some written printed information about the condition, about the decision that we've made, why we've made it, and what to do if they get worse. We're aware from other sites and other really good podcasts, WhatsApp, and so forth, that there is often this second week dip that patients get. So we're actually warning all patients that is a phenomenon that exists with COVID, and that if they feel that that's happening to them, it's really, really important that they seek reassessment via 111 or their surgery, or 999 if they're really, really unwell. So so a lot of patients actually, and in fact probably the majority of patients, are being assessed at that arrival point, and they're actually leaving very quickly from the site because all they needed actually to complete the assessment made by the triaging doctor on the telephone who sent them there. They're all by appointment only, by the way, no walk-ins. I don't know if I made that clear at the beginning. Everyone is being triaged by their own GP surgery, identified as a hot potential COVID case, and being sent down for further assessment. Often all they need is the SATs and possibly a properly done kind of objective respiratory rate if they've not been assessed on video. And then they can leave with advice. There's another group of patients who need a bit more detailed assessment. So these are people who are more unwell with a classic COVID presentation, let's call that amber, or patients who have COVID plus. So they've got potential COVID symptoms, they've had a fever, a temperature, but actually their main presentation is something that is probably unrelated. Abdominal pain, pelvic pain, something completely different. That group of people actually move to our main assessment area, which is sort of down a corridor and into the suite of 20 clinical rooms that I described, where they're seen in a more traditional consulting environment. I suppose the final group of patients are patients who are clearly significantly unwell on arrival. We've actually had 3 of those patients over the course of the week, and 2 yesterday within fairly quick succession of one another, who had a classic COVID presentation and were clearly unwell with low SATs and increased respiratory rates. And those people actually needed to be taken down in a wheelchair down the corridor straight into what we've identified as our resuscitation area, and receive oxygen, be looked after quite closely while we what we call an ambulance for those patients and arrange transfer. So it's interesting. That's why I said, oh, it feels like it's getting serious, because that was yesterday and we had 2 of them. So that's the setup really, Gandhi. I'm sure I missed out a lot. Obviously, PPE is really important.
Definitely.
Gandhi, we've got Gandhi organised the production of the word improvised doesn't do them justice, some maker community built visors. I thought you were about to pick one out of your pocket there, Gandhi, and lift it up.
No, so I've had to leave all of these at the hubs because that's where they're needed. Yeah. But I guess massive shout out to Hackathon Knots and to Tech Knots as well, 2 communities locally that have given us some real help in terms of generating, these extra visors that have given reassurance to clinicians. I think what was really interesting is that originally face protection, aside from the fluid repellent mask, was not part of what was needed for those in primary care. It was felt to be an additional piece of kit. But then goggles got added literally just last week to PPE requirements for clinicians in primary care, particularly if you're working in hubs and stuff. And also trying to source them is a real challenge. And these visors can duplicate as an option to try and help with goggles, because sourcing them is a real problem. Locally in Nottingham, we've got another solution coming, which is provided by the university. We're just waiting for that production line to become fully online. I think we are starting to see some of those pieces of kit come through. But, real massive shout out to that local community, to our makers, to our, tech communities that have really just stepped up and helped the local healthcare providers be able to continue working safely, which is a massive, massive thing. So definitely a big shout out there.
Yeah, and I would just say that was actually really, really important, because those maker community made visors have bridged an important point in time in Nottingham, because I think in order to get people on board with the hubs, the practices, there needed to be face protection. And actually the CCG solution has come quickly, and that'll probably be there at some point next week with the university made visors. But there was a period where CMCs had to operate, that wasn't available. I think we would have actually lost the buy-in of a lot of people if there wasn't face protection. So I think that was really, really important. So yeah, big thanks to everybody. And just to add, the procedures for staff arrival and departure and how staff are moving around the building and dealing with patients has been sort of carefully designed with infection control and PPE donning and doffing, etc. in mind. So we're designing a new facility, or at least the use of an existing facility in a new way, has enabled us to be quite strict about the PPE, which I think has been really good.
So I guess just briefly to mention the difference, we've got RCMC, and then we're going to talk about the tech. Fairly similar to Andy's, real logistical issues have been about things like parking, about the rooms and the flow that we've had, and making sure that people can get through the system safely. Having infection control go around with you was actually really helpful because it helped to clarify a lot of our processes and actually mean that some of the things we were thinking we had to do, we didn't have to do, and vice versa, which just meant that everything works more safer. But our difference is we don't really have that screening mechanism that Andy mentioned at his hub. We've not gone down that route, partly because of space more than anything else. So the estates that you have really does dictate what you can do. I think we've got the option of doing that, but it's a little bit more complicated. So we've not focused on that. And the patients we've seen similarly, fairly complicated cohort of patients that have either been okay with a bit of reassurance or needed admissions, and we are seeing that ramp up gradually over the next few days. Thankfully, we've not had to use our resource room yet. Oxygen supplies is a real concern. I know nationally that's becoming a bigger and bigger challenge. But obviously, this episode is focusing on the tech, and I guess a couple of things tech-wise definitely to consider when you're looking at creating your hubs. First and foremost, the triage before they get to the hub has to be on point. Having clinicians in the practices that are helping you, that understand the concept of safe and effective triage, and making sure that they are done properly, and with that, giving those clinicians the guidance of how to do what cases you need to be seeing in the hubs or the COVID in clinical management centres is really important, because otherwise you will get some toing and froing, and that's clearly what we don't want to do. I know, Andy, I think that's been a massive discussion, isn't it, in terms of which kind of patients we kind of should be seeing, which kind of patients shouldn't be seen, and that kind of stuff.
Yeah, I mean, definitely. And just to reiterate, I think it's important to consider the patient journey with regards to the hub as starting with the triage. And that's part of it, because that's where you identify the right and wrong patients. And that's where you're already building patients' expectation for what happens at the hub as well. I think that's something we need to do a little bit better next week, actually. So that's something that our team will be thinking about over the weekend, in terms of providing a little bit more detailed guidance for all the practices, so that they're triaging using the right tools and sending the right patients down to the hub. And obviously when we're talking about the triage, we've talked about use of video before, haven't we? But I think that can be an important part of the triage that they're doing, not essential for everybody. We've had a few patients down who you thought, I wonder if there had been video as part of this triage, whether they would have needed to come down, because a lot of the patients we're seeing are not that unwell, but worried, as well as the patients who are unwell. So that might have been a better tool. So I think we can perhaps reflect that in the guidance that we're giving.
Yeah, and I think that's an important point, that any patient, before they end up coming to one of the clinical management centres, in my view, should have had a video consultation before they come to us, because there's a fair cohort that I think would be safely managed by doing so. Yes, there are going to be the increasing number of patients that need the SATs doing, and that's effectively why they're going to end up coming down to us. But often just seeing the patient can give you some elements of reassurance, and also enable hopefully a better discussion. Now, clearly, if that doesn't work for whatever reason, whether it's reception, whether it's a patient not having the device and that kind of stuff, fair enough. But I think if you've got the capability of doing a video consultation, that should happen before a patient ends up at one of the clinical management centres. Interesting part of the challenge that we've had, and I know that this is probably something that's universal across almost every area, the fact that the clinical systems don't talk to each other as well as they could do, and therefore booking patients into these centres has been a massive, massive challenge. And interesting, we've got a comment from Adam asking basically about that problem. So in the chat, he's mentioned about the fact that he's got 2 System 1 practices and 2 EMIS practices, and they're having logistical issues of getting these patients booked into the centres.
Shall we describe the Nottingham solution?
Yeah, so we were slightly fortunate, weren't we, Andy, that our system that we have for our extra support service provided by
extended access.
That's the one, the extended access. I forgot the term. The extended access service that we have found a way of trying to get around this. That's a bit clunky. It's not as good as a directly bookable system, but it works. That's the key thing. And that's using a system called Zesty, isn't it, Andy?
Yeah. I was going to say, I'll describe, because I've been trying to get my practices to use. There's been some challenges. So GP Access, we set it up in the we rolled out our solution in Nottingham, which was led by the Federation, NCGPA. Give you a shout out. And the big problem was we have some EMIS practices who are a minority, and we have System 1 practices. And having a shared booking ledger was a problem that was identified 2 years ago when we were setting this up. And it was explored in depth at that time. And actually, the solution was to use a third bit of software called Zesty that I think people can search the internet for and find. And what happens is patients are booked using so there's a web link that opens up a Zesty page that has all of the sessions for GP access and now the hubs on it as well. And it was initially receptionists booking into extended access, and they book entering the patient details in on the website. And that goes to some staff who sit at our federation, who then actually manually transfer those appointments across to a System 1 ledger, which is a bit clunky, but it works for the extended access system. And it actually meant that there was an apparatus and a method available to allow us to operate a shared ledger with our shared ecosystem of System 1 and EMIS practice already there to use. So I think we were really, really lucky. One of the challenges is receptionists used to do the Zesty booking, and none of the clinicians really knew how to do that. But actually, if you're booking someone in this afternoon to a slot, the clinicians can't say, oh, well, they could, but if they say, I'll get the receptionist to call you or transfer you to make that booking, there's a danger that someone else books a slot. They might all have got in the time it takes to organize the booking. So we've been having to get our clinicians, or at least in my primary care network, get our clinicians to use Zesty, but it turns out it's really easy. So, so that certainly hasn't been too much of a challenge. And then in the hubs, very similar to in the extended access, we've got System 1 installed on all of the laptops, or all of the computers that we're using. And it's a System 1 ledger that's being used because that's the dominant clinical system in Nottingham. So all the patients, you have to log in, and that's how you run the patient list. But when you have an EMIS patient, all the machines have EMIS installed on them as well. So you just have EMIS loaded up in the background, and you just load up the EMIS record for that patient, read from the record, their triage details, their past medical history, anything else you want to know about the patient, but then write into System 1. And then after the consultation, because of the mechanisms already in place for GP access, there is a way that the staff at the federation actually produce a PDF. It's not ideal, but it's something that's already there and works, and that the practices know how to receive and process. The staff at the federation produce a PDF export of the information from the encounter, which is sent to the EMIS practice. But the EMIS practices know how to receive and how to access this already, because extended access has been running for a few years, and they receive and action the information coming from the practice in the same way. A bit of a long explanation, but that's what we've done in Nottingham. That might be helpful for other people.
Yeah. So I guess it's important to recognize that it's not perfect. It's not an integrated solution that would work universally, but it's making the best of what we've got with the time that we've got. And I think, the fact that we were able to lean on using this system rather than having to reinvent the wheel was very much appreciated. There's some familiarity in our local area with this kind of system, so that has helped quite considerably. Your other default option is just pen and paper and call it in, but obviously you've got the problems of awareness of slots and that kind of stuff that causes a massive challenge for people. And there's the risk that as we head towards the surge and the peak, that's going to cause a real problem for people. But that's not the only tech challenge we've had, is it, Andy? We've had another one, which is in some ways, you think about it as such a minor little thing, but it's caused so many headaches.
You're about to talk about prescriptions.
Yeah, so Andy knows this is how much pain it's caused both of us, but sorting out something as simple as a prescription for a patient has actually probably caused us more challenges than any other part of creating a clinical management centre. And that's mainly because we can't use EPS.
Or we can now, but from Friday.
Yes, so this was a fix that came in. This is hot off the presses. We managed to find a fix for it as of last night. And I know often primary care clinicians like to badmouth our IT partners because we think tech works one way and it doesn't because of some reason, and we don't quite understand that reason, but there's a techie reason for it, and therefore it's very easy to bag on the tech people and stuff. But to be fair, they are clearly working off the charts in terms of trying to get everything up and ready and I think there is that disconnect in some way in terms of how we think about what tech can do and how it can do it and stuff. But something as simple from our perspective as clinicians of being able to use EPS and not working was a real problem, because we weren't able to print because there weren't enough printers. And then when we had printers, pharmacies weren't able to accept physical prescriptions because of the infection transfer risk of having a piece of paper. So therefore, we were having to figure out mechanisms of how we can send EPS prescriptions. So we had to call the practices that the patient came from, wait for that to happen, say, can you sort it out for us? There's a clinical risk that comes without the delay, that comes out. So many potential flaws that came through it. And thankfully, as we said, as of last night, we've managed to find a mechanism for being able to enable EPS prescriptions through our GP Plus hub that runs the back end of the system. But yeah, something as simple as a prescription caused so many challenges for us.
Yeah, so we'll see if it continues to work into next week. Yeah. Oh, the other thing I was going to say was, because of the extended access, we already had our data sharing across the city. We had data sharing arrangements and agreements in place as well. Just so that's another bonus.
Yeah, and it's making sure you've got those on point. So we'd hope that a lot of people that have already set up their primary care networks have some of that done, if not majority of it set up already, with things like extended hours access and stuff. And it's just a case of amending those to make it a bit clearer and more effective. But making sure the governance is there is unfortunately something that we have to do. So get people to help you do it. That's the first thing I'd say. And then hopefully it will work more effectively. I guess one thing I did want to talk about, so we have seen examples of other places where they've been doing hubs and management centers in a different way, particularly using tech even more so. So using complete remote consultations, even when patients attend the room. So using boxes with SATS probes, temperatures, and a device in there to enable the consultation. The patient doesn't even have to go into the vicinity of the patient at all. I mean, what's your thoughts on that, Andy?
I'm not 100% convinced about it. I think it's a really good idea. I've not seen reports of where it's actually being done. I'm sure you have, and you can correct me. I think it's a good idea. I think it's very impersonal, and actually a lot of the patients that I've seen come through the hub. Again, two categories. So those who aren't unwell, we've been able to observe them from 2 meters and never in full PPE and never step within 2 meters of them. They've done their own stats reading. We've stayed a distance and they can go out the door, and they've only stepped a few meters in. So I think the infection risk has been kept quite low with those patients anyway. The other set of patients, they're clearly unwell, and actually you've got to go and touch them. They're panicking. It's actually quite an emotional situation for them, and I just don't think you could watch them on a video from a room next door and be effective at managing that patient. And you've got to go in and put some oxygen on and things like that. They're not going to do that themselves. So I'm not 100% convinced by that, although I think the idea is right. And also I'm not quite sure what it adds apart from the presence of the SATS probe, in addition to remote, just remote consultation via video. I think a SATS service is potentially a good idea, where patients can go somewhere or have a volunteer or somebody come to their house just to get the SATS reading to enhance the remote consultation. But yeah, that's my take. What do you think, Andy?
I think similar to you. I think there's definitely a situation where it can work, and with that lower element of risk patient that you see that potentially doesn't need that significant involvement, it may be an option to use those. And I think the thing that will dictate how well and how effective that is needed is actually going to be the workforce element. So if our workforce does massively get trimmed out, and that effectively we're having to run on, skeleton staff to facilitate this may be a mechanism that allows one doctor to provide care to a much larger footprint, because they're working remotely to organize that. So I think if that was to happen, that's where we will see those areas work really, really well. I think you're right, that remote SATS service mechanism, so SATS in a bag or various other mechanisms I've seen. So, like you said, volunteers dropping off SATS bags to patients' houses so they can just take the reading if they don't have a probe themselves, or similar. I think that's got some real value, because one of the things we know with COVID, it's the SATs that determines potentially how well these patients are going to get, particularly where in the timeline of their virus journey they are. And if you can get that one piece of information, that's the thing that will help you manage this patient most effectively. Because unfortunately, we know that things like Roth score and stuff that we've talked about previously are thought to be less effective because they are missing out patients. But that's the key thing. So I think if we've got those mechanisms in place, great. If we don't, like you said, as long as you've got the estates to support you, the space to do it, actually the hubs can still be effective and mean that these patients can be assessed more effectively. And then for those ones that you do just have to see physically, you see them physically. And you're right that this question of impersonal care is something that I think many clinicians are really going to struggle with, because it's not how we're used to doing things. It's not how we're comfortable doing things. We're not able to use our consultation skills that primary care is just excellent at doing. So as a result of that, it becomes a much more challenging consultation, both for the patient and for the clinicians as well. And obviously that proves an interesting challenge that we've not had to deal with before.
Yeah, absolutely. And but for some of these patients, you just need to go in the room because they need the oxygen. They actually need hands-on care. But I'm sure those places that are experimenting this, they'll acknowledge that, they'll have the clinicians to do it. Very interesting point about being able to utilize self-isolating workforce within the hubs through remote presence there. I think that's something that we may all need to pivot to, and the technology's there for it. We have tablets, we have mobile phones, that can be carried by other members of staff or deployed by other members of staff who perhaps aren't doctors or AMPs, but are at least present. So there's still yet more innovation that we can lean on if we need to. It's nice to know that that's there.
Yeah, and there is even the option of self-service elements of using these tech kits. So I know we've come across companies like MedicSpot and Techie Hub that provide these pieces of kit that allow patients to support their self-examination, directed either by the clinician or with a healthcare assistant supporting that and stuff. And these are mechanisms that can work quite well, I think, and potentially have quite a lot of power in terms of supporting, clinical management centres, but actually even moving forward in terms of home visiting and that kind of stuff. And obviously that's another challenge that we're all having to face, and some of the stuff we've talked about has massively helped with that. So the transport aspect is something you can't forget when it comes to these hubs, and actually having the black cab method, the Hackney cab method, has really been helpful, I think, at setting this up, and also for our visiting service. So effectively those are our visiting cars, because it gives the clinician enough space to do everything. It's got their own kind of cabin for them to don and doff in if it's chucking it down with rain. Thankfully we've had some really nice weather the past few days. It's not been an issue, but let's be honest, it's April, it probably is going to rain soon. Yeah. So we just need to be aware that, these people need the space and the opportunity to do that, and that black Hackney cab method may actually be a really good method of doing so. Yeah.
It's probably actually just worth mentioning that service. Just from the outset in Nottingham, we sort of conceptualize things as, okay, 4 hubs and the 5th hub is visiting, because like many places, I'm sure we've anticipated that home visiting to potential COVID patients is potentially going to be an enormous task. So we actually developed the 5th hub, the COVID home visiting service from the outset, and actually the GP extended access service, which is delivered by the Federation from a location in town, has converted itself into the visiting service, which I think again is a big achievement. There's so many big achievements being achieved so quickly at the moment. It's really impressive.
Definitely. So we've talked a bit about setting up, a clinical management center or a COVID hub or whatever you want to call it. I know there's official terms and unofficial terms and stuff. And we hope that this has given a good summary of some of the challenges we face. I know both myself and Andy are more than happy to talk to people if they want further advice. I know I've spoken to a couple of our colleagues on the phone about the journey we've had and the challenges we face with certain things and how to do that. So if you are interested in further discussions on that topic, feel free to contact us. Both of us available on Twitter. So Andy's at Draw Foster and I'm at Dr. Gandhi 52. But we did want to talk about a couple of other things just before we finish off this session. And we've got some really awesome resources for you. So we're going to go to our news article.
Okay, let's cue it up.
Yeah, so Andy's just going to bring up on screen. So some of you may have come across this recently, but obviously with the challenges that everyone's facing with the COVID and stuff, there's the support packages that have been introduced by the government, led by Rishi Sunak, in terms of supporting businesses to help manage their staffing challenges that they're having, because at the end of the day, some businesses can't have people working. So quite a few of the tech companies have said that they wanted access to this and they may or may not be eligible. And one of the interesting names that came up in this was Babylon, which many people in primary care will be aware of. You know, me and Andy have covered Babylon several times, both in admiration and in challenges, in the fact that they basically disrupted primary care 2 years ago.
Yeah, great disruptor.
Sorry?
I know, I was just saying, fantastic example of disruption, not always unhealthy. Yeah.
Well, it seems that, you know, all of these companies are now unfortunately victims of the ultimate disruptor, that is COVID, effectively, which has meant that every aspect of our lives has been disrupted. And you know, that they've said that they wanted, in principle, to be eligible for support from the government. And I know subjectively a lot of colleagues are feeling that this is a bit of a cheeky ask by Babylon, to be honest.
Well, Gandhi, I'm just thinking, why? You know, because you would have thought that they're set up really well to continue to deliver care in a way that reduces infection control risks. People don't have to go out their homes. That, you know, they're self-isolating. Surely they should have done well, I would have thought.
Yeah, and interestingly, Babylon have created quite a few services to manage COVID quite effectively. So they've got a COVID assessment service, or some sort of thing that gives checks on the health of patients, similar to, I guess, what Accurix have recently developed, which is a questionnaire base that practices can use to check on the daily health of their patients and things. So similarly, you know, I've read a lot on the forums and that kind of stuff about the perspective that many clinicians seem to have about this, and it just seems very cheeky in some ways, is the best way to describe it. Now, obviously, me and Andy we don't work for Babylon. I know I did, but I don't anymore. And we don't know the ins and outs of this. We're basically going off the information that's been reported by the BBC and other news outlets and stuff and things. But, you know, this is a company that has had millions of external investment, and they're saying they want access to additional funding. They're open to the same funding that primary care has in terms of trying to manage things. So obviously, you know, general practice has seen a massive shift over the past month in terms of a lot of non-regular work being stopped, potential access to things like COVID management, finance in the future, not now. And obviously we do have some elements of protected status compared to other businesses. But, you know, we're all in the same boat, and yet, you know, you don't see the rest of primary care trying to...
Well, I think the interesting thing is, so we're in a position, so we don't have the inside track, so we don't know, so we can speculate. Yeah. But what I was thinking, Gandhi, is that perhaps Babylon isn't, well, I'm sure we can assume it's not profitable at the moment. You know, it's in that R&D development, gaining users sort of phase of a tech company, and it's probably highly dependent on external finance. And perhaps they're worried that post-COVID, external finance might not be being deployed to them in the way that it has been so far. Maybe they're looking for, you know, a way to compensate and mitigate for the potential challenges they see coming up in an environment where there perhaps isn't so much cash floating around. That's maybe my thought. I don't know.
Or is it the fact that they've just lost their user market? So obviously in the past 4 weeks, we've seen almost every single practice across the country move to remote working, whether that's via telephone or whether that's via video. And are we seeing them losing their potential?
They're losing their USP.
Yeah. Don't know. Time will tell us. I think it's an interesting article to discuss, and we've seen this going around the forums and stuff. So we wanted to raise it as an issue. You know, has the disruptor been disrupted? I guess is a question. Time will tell us.
We will see. So yeah, Gandhi, do you want to just give a shout out to some of the resources that are out there for practices keeping up to speed with COVID developments?
Definitely. So part of this the series we're doing at the moment is obviously a slightly more COVID focused ones, and me and Andy have been trying to keep a track of various different things that are available. We both obviously love podcasts, so a couple we're going to give a massive shout out to. So our colleagues over at Primary Care Knowledge Boost have been doing a regular weekly COVID series. So I think they've got 4 podcasts in total at the moment. queued up at this point. Definitely recommend having a listen to it. Yes, it's got a slightly Manchester-based theme because that's where they're based and that's who they're catering for. But I must admit that the clinical information and the guidance that they're providing is just on point. It really is clear, sensible little packets of information. To be fair, I've listened to I think 3 out of the 4. I haven't got through the 4th one yet, but the 4th one does look interesting. It's about managing the palliative patient in these kind of situations and stuff. Definitely recommend having a listen to those. In addition, MB Medical have pulled a blinder, and every week they've got their clinician Neil Tucker giving a regular update on the evidence behind all the stuff that's coming through with COVID and stuff. And yeah, again, an amazing podcast. Really recommend having a listen to it. In terms of quality and content, yeah, I mean, tried and tested company that provides amazing information for clinicians. Can't miss out Red Whale. They're another provider of educational content. So slight declaration here. I was part of this webinar, but they've got a really, really good quality webinar on remote working, both telephone and video consultations, which covers a lot of the content that's in our episodes. Our stuff kind of goes into a little bit more depth, but if you want a good overview of how to do telephone and video consultations and all the things you need to be aware of, definitely check that out. And it's free, like the podcasts are as well. So you don't have to pay anything for them. And our last one, so we've worked in the past with a company called Orca, and they've created a app library for COVID-based resources. So definitely have a look at this. It's quite an interesting catalogue of applications that you can share with patients to help them manage through these kind of situations and stuff, and would definitely recommend that you guys check that out. And it may be a great way of supporting your patients in terms of all the different stuff that's going on. In addition, we're going to mention our own resources that we've got for you guys. So over the past couple of weeks, myself and Andy have been churning out quite a few different video tutorials and stuff of how to do various things. So we've got some playlists that include how to use Zoom, how to use System 1, which includes our recent episode on basically a half-hour tutorial of using System 1 if you've never used it before. So particularly for those people that are working in clinical management centers, hubs, or just having to work with System 1 afresh, half an hour, pretty sure it'll be enough to get you familiar with the system enough to do the basics of do a consultation, issue a prescription, issue a med 3, all that kind of stuff. And also Accurix. And so this is a slight exclusive I haven't told Andy about either. Yeah. So whilst we've been filming this live, I've released 2 episodes of how to use Accurix photo mechanisms.
Wow, you're so productive, Gandhi. I didn't even see your hands move.
Yeah, I know. So effectively, at the beginning of this week, Accurix released some new functionality, one of which was the ability for patients to send photos. So whilst their video consultation platform is amazing, and we've done a few things on that, one of the interesting things that you can now do is you can have a patient send you a single image in response to a text message that you sent. And this can be really useful, particularly for patients where you've got real challenges with reception, with the ability to do video consultations, and when it's just simply you need to have a look at something. So the 2 videos we've got on there, one is designed for patients, and it literally walks the patient through how to do the process. So from when they get the text message to sending that back to you as a clinician, and how to do it properly. Because there are a couple of things you need to be aware of. If you take it in portrait fashion, unfortunately, the image will come back to you in lopsided. So it does need to be done landscape, and it basically helps the patient to do this and shows them why they have to do this. It's a really quick video. I think it's about 3 minutes in total as well. And then there's a clinician one that basically shows you what you do from the clinician perspective, from sending the message to the patient, to receiving it, to processing it, and if need be, saving it as well in the record. Now, I know a lot of people think, why would you want to save it? Well, majority of the times you probably don't, but there may be occasions where actually having that image can be useful to compare for future references. And things like spreading cellulitis is a really good, easy one. Unusual rashes, sending them onwards for referral, potentially as well, to show this is what I'm concerned about, really effective way. It is a System 1 focused one, because at the end of the day, System 1 is what I use. But it will show you how to do it step by step. Again, it's short. It's about 5 minutes in total. Definitely check that out and feel, if you want to have a look at more stuff, we've got our playlist for Accurix as well. All of those links that we've just mentioned are in the show notes. So if you are watching this now, have a look at the show notes. The links are there. Pick the ones that you feel useful. And as an extra freebie, some of you may be aware of this, but EE, so the mobile phone company EE, are offering all of their current users that are working in the NHS unlimited data until October. and you simply just need to register for it. So if you're on the mobile phone company EE, just click on the link that's in the show notes and fill in the form, and then they will get back to you in a day or two, and you will have unlimited data till the end of October. And we thank them for that amazing offer.
So yeah, so that brings us to the end of today's live show. A little bit longer than planned, but there's so much going on because of the COVID-19 pandemic. Gandhi, I just had an idea for a future episode, just hot off my mind. We should plan the next pandemic and the what if this happens again in 5 years' time? Ooh. Where will tech be, and how would it all be deployed? Be a nice little planning episode. So
well, we've been through it once. Hopefully we won't have to go through it again, but you never know. There could be a different emergency. Hot off the presses, Ebola's back. Don't know if
who knows? But capture the learning and plan for the next one. That'd be a really nice episode to do. So yeah, that's all I've got to say for today, Gandhi. Anything else?
No. So thank you everyone for joining us. As always, if you've got any comments or questions, myself and Andy more than happy to try and answer them best as you can, whichever social media platform you prefer. If you are listening on the podcast, definitely subscribe and make sure you leave us a review, especially on iTunes. It really helps, and we love reading those comments. And on YouTube, make sure you click the bell, subscribe, leave us a comment. We guarantee you'll get a reply. Massive shout out to all of our EGP learners supporting us on YouTube. The channel is doing amazingly, and your comments are just so inspiring for us, myself and Andy, in terms of continuing to do this content and directing the content that we produce for you as well. And as always, EGP Learning is here to help save you and your patients time by tech enhancing your primary care and learning. And we'll catch you in the next episode, guys.
Okay, thanks, guys. And take care of yourselves. Look after yourselves and each other. Now I'm looking for the stop button, which I will find.